I'm going to be talking on acute aortic syndromes. I have no disclosures. My objectives are to review the common as well as the unusual manifestations of acute aortic syndromes on CT and to discuss important imaging findings that need to be urgently communicated to the cardiac surgeon or the IR radiologist. Acute aortic syndromes are a medical emergency characterized by high risk of aortic rupture and sudden death. The majority of patients present with acute chest pain radiating to the back. Acute aortic syndromes include acute aortic dissection, acute intramural hematoma, and symptomatic penetrating atherosclerotic ulcer. A causal relationship is proposed which links ulceration to intramural hematoma and aortic dissection. Patients exhibit some or all of these findings and may progress from one to the other, demonstrating that there is a link between ulceration, intramural hematoma, and aortic dissection. Of the multiple imaging options, CTA is used most commonly to assess for acute aortic dissection in the hemodynamically stable patient and transesophageal echocardiography in the hemodynamically unstable patient. CT angiography is the first-line imaging test as it is readily available and it provides a rapid, immediate diagnosis of aortic pathology, particularly in acute intramural hematoma or aortic dissection with a high sensitivity and a high specificity. At our institute, all our suspected acute aortas undergo a non-contrast acquisition at 5mm collimation. And this is so that we can diagnose an acute intramural hematoma, which is this crescent of high attenuation in the proximal ascending thoracic aorta, characteristic of an acute intramural hematoma. And this patient also has had bleeding into the pericardial sac. Non-contrast CT performed for other reasons may pick out displaced intimal calcification, which is also diagnostic of aortic dissection. We then follow this by a contrast-enhanced dedicated CT angiography run, which includes imaging the chest, abdomen, and pelvis with a high-density contrast medium at a high flow rate, and depending on the scanner, you can use 80 to 120 mils of contrast. One can use either a timing bolus or triggered delay. We use thin slice collimation at 1.25 or 1mm collimation and recon these images at even thinner slices. And all our acute aortas are performed with ECG gating. And this is where ECG gating helps. This was a case that was referred to the University of Michigan for surgery for a Stanford Type A aortic dissection. But when we look at this linear filling defect in the ascending thoracic aorta, we see that it extends into the right atrial appendage. So is this real or could this be artifactual? We did an ECG-gated scan, which clearly shows that that was an artifact. There's no flap within the ascending thoracic aorta. The patient did not need surgery and was discharged home. Our contrast is injected via the right arm and not the left because you may have dense streak artifact in the aortic arch and the arch vessels when contrast is injected from the left arm. We also use MPRs, which are really useful for communicating findings to the surgeons and clinicians, and they're particularly useful at branch points for deciding endovascular or surgical approach and how far is the abnormality, particularly from the left subclavian artery origin. So here we have MPRs on a patient with acute aortic dissection, where you can see the dissection flap extending from the aortic root to the arch, to the descending thoracic aorta, and the abdominal aorta. And this is a very nice way to also communicate these findings, not only to the referring physician or surgeon, but also to the patients and their families. So let's talk about acute aortic dissection. This is the most common thoracic aortic emergency, presenting more commonly in males than in females. And if untreated, an acute ascending aortic dissection will result in mortality that incrementally increases with time. It's a 36 to 72% at 48 hours, increasing to almost 91% at 1 month. However, when surgically treated, the 5-year survival rate is 75%. The inpatient mortality remains at 20% over 20 years. The risk factors for aortic dissection include hypertension, aging, genetic causes, and predisposing weakness of the aortic wall. And the less common risk factors include pregnancy, bicuspid aortic valve, iatrogenic causes, coarctation, and Lloyd-Stitch syndrome. Patients classically present with acute, severe substernal tearing chest pain radiating to the back in more than 3/4 of cases. They could have signs of aortic insufficiency, asymmetric pulses in the upper limbs, or absent femoral pulses, which is seen in up to 1/4 of patients. And an atypical presentation would include the absence of chest pain, which can be seen in up to 1/5 of patients, and the patients would present with end organ ischemia from branch vessel compromise. So they could present with myocardial infarction and congestive heart failure when the coronaries are involved, or from abdominal pain and mesenteric ischemia when there is mesenteric vessel compromise, and stroke, confusion, coma, and syncope when the head and neck vessels are compromised. The mechanism is a tear in the aortic intima with a longitudinal split in the media and the creation of a false channel in the media. Acute dissection is considered chronic at 2 weeks. The typical appearance is this, where you have a true lumen and the false lumen. The true lumen here is central, and often it shows, when there's differential flow, it shows increase of pacification when compared to the false lumen. And here you can see a tear in the flap, so you're looking for entry and re-entry tears. The dissection flap extends through the aortic arch all the way down into the abdominal aorta. An atypical appearance is this, where you do not see a double barrel aorta like we did before. But what you see here is a crescent of low attenuation. Sometimes it can be hard to see around this ascending thoracic aorta. And on this contrast-enhanced scan, it's difficult to know whether this is an aortic dissection, but this is clearly seen on the non-contrast images. And this is where non-contrast images are extremely useful to diagnose acute intramural hematoma, where you can see this crescent of high attenuation. On CT, it is important to determine the extent. Is this a type A or is this a type B aortic dissection? And I'm talking about Stanford Type A and B. It's important to identify the true and false lumens, the entry and re-entry tears, the source of perfusion of major branches, whether it's from the true lumen, false lumen, both lumens, or can we not tell, and what are the complications that occur as a result of the aortic dissection. Classic aortic dissection begins at 3 distinct sites: the aortic root, 2 centimeters above the aortic root, and just distal to the left subclavian artery takeoff. So here we have the Debakey classification, which is a little bit complicated. In type 1, you've got a dissection flap involving the ascending thoracic aorta and the descending thoracic aorta. With type 2, just the ascending thoracic aorta, and with type 3, the dissection flap is seen just in the descending thoracic aorta. However, it's much more simple to use the Stanford classification, where we want to know, is there a dissection in the ascending thoracic aorta? And if that's yes, then it's Stanford Type A. And if it's absent in the ascending thoracic aorta, then it is Stanford Type B. So here's our double barrel aorta, a Stanford Type A aortic dissection beginning in the aortic root and extending down into the abdominal aorta. And the flap can extend for a variable distance. It could involve the entire thoracoabdominal aorta terminating in the iliacs, or it could be something such as this, where the flap is a little complicated and it's present only in the ascending thoracic aorta and it terminates in the distal arch. You can see that there is differential flow with decreased flow or slow flow in the false lumen. And this dissection, this patient has aneurysm of the ascending thoracic aorta, which is associated with the dissection. Stanford Type A is a surgical emergency, as a dissection flap in the ascending thoracic aorta can result in death from wall rupture, hemopericardium, and tamponade, occlusion of coronary ostia with resultant myocardial infarction or severe aortic insufficiency. Here is a patient who has an acute intramural hematoma, which is treated similarly to an acute aortic dissection involving the ascending thoracic aorta. This is Type A, which has led into a hemopericardium. This patient was taken for surgery. You may also see something such as this on the contrast enhanced images, or even on the non-contrast. You see this smooth low attenuation surrounding the pulmonary artery. And this is blood seeping into the adventitia of the pulmonary artery, as the aorta and the pulmonary artery share a common adventitia. If there is a significant amount of blood in this space, it can narrow the pulmonary artery significantly. So this is not a dissection involving the pulmonary artery, but this is blood that has seeped into this common adventitia in this patient with Type A aortic dissection. With Stanford Type B, we do not see a flap in the ascending thoracic aorta. Here, the flap begins. You can see the tear in the distal arch, just distal to the left subclavian artery origin, and it's extending into the descending thoracic aorta all the way down and terminating in the left common iliac artery. On the CT scans in aortic dissection, we have to identify the true and false lumens. False lumens are identified by the presence of several signs, and we will look at these. Sometimes it may be difficult to differentiate the two, but this is quite simple. The true lumen is central. It's often central and small when compared to the false lumen. And as I mentioned, you may have differential flow, because it's in the first case here, you've got slow flow in the false lumen. But if you were to image a few seconds later, then you may see that the flow there would increase and may be equal to the true lumen. So that's what we're looking here. Equal flow on this first patient, differential flow on the second one. When you see this beak sign, a sharp beak-like appearance here, that denotes the false lumen. And you can even see that here. And you may sometimes see cobwebs or thread-like linear low attenuation areas within the false lumen. So what happens to the false lumen over time? It can thrombose, it can decrease or increase over time. When it increases, it can become aneurysmal and it can rupture. And that is why it's very important to follow up, to do follow-up CTs in this group of patients. So let's look at what happens to the false lumen. Here was a patient with aortic dissection where you're seeing this was basically thrombus and not slow flow in the false lumen. And several months later, you see that the true lumen has increased in size, but the false lumen is decreasing in size. Good sign. Whereas in this case, here's your true lumen posteriorly. This is a partially thrombosed false lumen, which is aneurysmal. It's also got some calcification in the wall, and calcified thrombus too within that false lumen. And here we're seeing true lumen aortic dissection, and this aortic dissection has ruptured into the posterior mediastinum. There's a localized contained hematoma posteriorly surrounding the esophagus, and there's also hematoma adjacent to the aorta, and the patient's got a small left pleural effusion. We should evaluate for the perfusion of major branches of the arch, the mesenterics, and the renals. So here we see that the aortic dissection flap extends into the innominate, left common carotid, and also the left subclavian. And when we go down, we see that the cilia comes off the true lumen, and so does the SMA and IMA. And the right renal artery arises from the true lumen, whereas the dissection flap extends into the left renal artery. So when you're looking at the perfusion of both the kidneys, you can see that there is slow flow in the false lumen. Hence, there is this, the left kidney appears less dense or less perfused than the right, but if you were to image later, it would show good perfusion. So acute complications could include branch vessel compromise from static or dynamic obstruction of the branch vessel, and mortality significantly increases with end organ ischemia to the brain, heart, bowel, kidney, and spinal cord. So the dissection flap is a moving structure. It's not static. It moves up and down. So if you had branch vessels coming off, you can see that they could be dynamically obstructed by this moving flap, or the flap could go into the vessel, have some thrombus around it, and result in static obstruction. So what do I mean by all this? This is an image from a radiology article from many years ago by David Williams, one of my colleagues at the University of Michigan. And what he's showing in these diagrammatic pictures is that when you have a static obstruction, here is your true lumen, here is your flap. You can see the flap is going into this branch vessel. It's basically obstructing flow, and there is thrombus surrounding it, really significantly narrowing this, and there's no flow going to this vessel. With dynamic obstruction, this flap is moving like the one that I showed you, and then it's like a washcloth overlying this outlet, and basically it's causing compromised flow there. And when you may have a combination of the two when you have static and dynamic obstruction, and oftentimes a fenestration is done followed by stenting of these vessels. So let's look at this case. This is a 67-year-old female with hypertension, polymyalgia rheumatica, who presented with acute chest pain, aphasia. She was unresponsive, and an outside CT showed acute type A aortic dissection. The patient was intubated, and they came here. So let's just look down at the aortic root. We see a flap. So this is a type A aortic dissection, and we can see that the flap is extending into the ascending thoracic aorta, into the arch vessels. And you can see that here, this is the false lumen. We had a head and neck CT as well, but the true lumen is becoming smaller, and then it's obstructed. And we've got the flap also resulting in significant narrowing of the true lumen in the left subclavian artery. So moving down, the flap extends through the descending thoracic aorta. You can see the true lumen is really tiny. And then as we are coming past the diaphragm, we're seeing that the celiac is arising from the false lumen. And when we come to the SMA, here is the flap, and here you're seeing no contrast there. This was from static as well as dynamic obstruction of the SMA from this flap. And then you can see the differences in perfusion, where there is decrease or amount of contrast perfusing the cortex here compared to this, the left side, and that was because the right renal artery basically also has compromised flow from dynamic obstruction by this flap. And as we go down, we see the IMA arising from the false lumen. Look at this collapsed true lumen in the distal aorta, and then we see that even in that left iliac artery, all of this is false lumen. Here is the true lumen, which is really collapsed. So that's your SMA, where we saw the thrombus. Here is your dynamic obstruction of the right renal artery. And this patient underwent IVUS, and they had dynamic obstruction of the right carotid artery, as well as the right renal artery, and dynamic and static obstruction of the SMA. They underwent fenestration with stenting of these vessels. This was a slide that was given to me by Sanjeev Bala, and in this case, it's important when we see a dissection flap in the ascending thoracic aorta or in the aortic root and ascending thoracic aorta, and then we see it in the arch or distally or here in the descending thoracic aorta. But if we don't see a flap here, we should worry as to what is going on with this patient. Are they two different areas of the aorta involved with the aortic dissection, or could this have happened because there is bunching up of the flap, and this was from a tear, a circumferential tear of the aortic dissection flap in the ascending thoracic aorta, and then it's basically pulled up into the arch and all bunched up because of intimal intussusception. This needs to be urgently communicated to the surgeons. Moving on to the second entity, which is acute intramural hematoma. Basically, what happens is that there is a spontaneous hematoma into the aortic media from vasa-vasorum infarction. This is a variant of dissection, also called atypical aortic dissection. An intimal flap is absent, and there is absence of re-entrance tear from the media into the lumen, which leads to the development of an acute intramural hematoma. And this is more common in the elderly. The prevalence from the IRED registry is 5.7%, and 16% of patients with acute intramural hematoma progress to aortic dissection. The overall mortality is similar to classic aortic dissection, and treatment is also similar, with the ascending or type A treated surgically and the descending or type B treated medically. On imaging, we see a thickened, eccentric crescent, or sometimes a circular area of high attenuation, which tends to vary with time. And this high attenuation is seen on the non-contrast part of the study. This can progress to typical dissection. It can lead to pericardial, pleural, or mediastinal hemorrhage, and it can rupture. So here is our case that we'd seen before of a crescent of high attenuation on the non-contrast CT, which doesn't enhance on the contrast-enhanced CT, which has led to hemopericardium in this patient. And they also had some contrast that was seeping into the adventitia of the pulmonary artery and extending along the pulmonary arterial branches. The dissection looked more classic distally in the descending thoracic aorta. Here is another patient with acute intramural hematoma, and in this case involving the proximal descending thoracic aorta. And although this is thought to be a dissection where there's no communication between the two lumens, sometimes there has been recent documentation or a few publications talking about micro tears in the intima that result in the acute intramural hematoma, and you may see some mild irregularities at the interface of the true and false lumens. You may sometimes see little pools of contrast within the intramural, basically with acute intramural hematomas, or even over time when you're following these patients up, you may notice these pools of blood, and these are called intramural blood pools or branch artery pseudoaneurysms. They are thought to occur from injury to branch vessels, particularly the thoracic vessels, subcostal arteries, or even the lumbar vessels at branch points where they basically come off the aorta and not along the pleural surface. The findings that are associated with increased mortality in patients with intramural hematoma include Stanford Type A, A mural thickness, it's important to measure how thick the intramural hematoma is. A mural thickness of over 10 millimeters, an aortic diameter of over 5 cm, presence of a penetrating ulcer, rebleeding on serial imaging, or extension of the thrombus on serial imaging. Lastly, I'm going to be talking on penetrating atherosclerotic ulcer, and a symptomatic penetrating atherosclerotic ulcer constitutes acute aortic syndrome, part of the acute aortic syndrome. There is a focal atherosclerotic ulcer which penetrates into the internal elastic lamina, and it extends into the media right up to the adventitia, and you may have some surrounding subadventitial hematoma. This focal irregular outpouching erodes the lamina, and it is often seen in the presence of extensive atheroma, and more commonly seen in the descending thoracic aorta. Coexistent aneurysms are common. It can result in acute intramural hematoma and or aortic dissection, and the consequent dissection with a PAU is less extensive and has a thicker static and sometimes a calcified flap. It may cause acute or subacute rupture. So the type A or ascending aortic penetrating atherosclerotic ulcer is treated surgically, even if asymptomatic, as the risk of rupture is 33 to 40%. With a type B, these are usually managed medically, but when they are associated with an intramural hematoma, they're treated with endovascular treatment. So in 2/3, the ulcer and adjacent aorta are stable in size over time and they're medically managed. And in 1/3, the ulcer or aorta enlarge over time and may require surgical or endograft treatment. Here we have contrast outpouching from the aortic arch with surrounding small amount of thrombus. And this is a penetrating atherosclerotic ulcer. We can see the neck there. And here is a large, the penetrating atherosclerotic ulcer led to a large pseudoaneurysm with thrombus. And this was treated surgically. Let's look at this case here. We have an acute intramural hematoma. There's also some low attenuation, some thrombus there, irregularity of the interface between these two contrast-enhanced and non-contrast-enhanced portions with a little bit of calcium. So here is a crescent of high attenuation, compatible with an acute intramural hematoma, which is difficult to pick up here. You could wonder, is this just thrombus? And this was from this penetrating atherosclerotic ulcer that had bled and led to the intramural hematoma, acute intramural hematoma. And this patient was treated with an endovascular graft, and you can see that the aneurysm sac, the excluded aneurysm sac, is thrombosed on this image. And then several months down the road, that aneurysmal sac had shrunken in size and decreased significantly in size and almost was obliterated. So why it's important to treat these and follow them is because they can result in an aortic rupture. A periaortic hematoma or contained rupture is more common with intramural hematoma than with classic aortic dissection, according to the IRAD registry. And with aortic rupture, you may see hyperdense thickening of the aortic wall. Blood collects between partially disrupted aortic wall layers, mediastinal hematoma, hemorrhagic pleural effusion, hemopericardium, which is less common, and you may see signs of impending hypovolemic shock. Here is a patient who's got a contained aortic rupture from this descending thoracic aorta, and you can see the patient's got pleural effusions as well. And here is an intramural hematoma, which we see in the descending thoracic aorta, which has ruptured into the pleural space and resulted in a hemothorax. And here is the blood leaking into the periaortic area and into the pleural space. And this patient did not survive. Acute aortic syndromes cannot be distinguished from each other clinically, and hence imaging is crucial for determining the type of acute aortic syndrome, identifying the location, whether it involves the ascending thoracic aorta or just the descending thoracic aorta, to determine the extent of the pathology, to look at branch points, and to identify anatomic complications. So the take-home points are: recognize and urgently communicate findings of acute aortic syndromes that may require urgent emergent surgery or intervention, particularly in the case of type A aortic dissection. This is the double-barrel classic aortic dissection. Acute type A intramural hematoma with hemopericardium, a penetrating atherosclerotic ulcer that has resulted in acute intramural hematoma and aortic dissection, and branch vessel compromise. Here you can see compromise to the right renal artery. And I thank you for your attention.